Welcome to SARC Talk. SARC is a nonprofit pan-sarcoma research organization that develops and manages clinical trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review innovative scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode number 3. My name is Scott Okuno, a medical oncologist at Mayo Clinic and Chief Medical Officer of SARC. All episodes are posted on our website, Spotify, YouTube, SARC channel, and wherever podcasts are available. Today, our guest for SARC Talk is Dr. Shreyaskumar Patel, Professor of Medicine at MD Anderson. He holds the Robert R. Herring Distinguished Professorship in Cancer Research. He is the medical director of the Sarcoma Center at MD Anderson. He has published widely and is section editor for sarcoma for the Current Oncology Report. He is the past president of CTOS. He has been the previous chair of the Clinical Research Committee of SARC and is a member of the Scientific Steering Committee of SARC. He is presently chair of the Medical Advisory Board and member of the Board of Directors for the Chordoma Foundation. He has been program chair for CTOS as well as Sarcoma Track for ASCO. It is my distinct privilege to welcome Dr. Patel for SARC Talk. Welcome, Dr. Patel.
Thank you very much, Scott. It's an honor and pleasure to be here.
Thank you. First of all, we do appreciate you being here, and I know that your path to MD Anderson is unique. Maybe you can describe your path to MD Anderson.
Yeah, sure. So let me try and summarize almost 40 plus years in hopefully just a couple minutes. After finishing medical school in the early 80s, I got married to my very good friend and classmate, and we decided to emigrate to the United States. Interestingly enough, after med school, a bunch of us friends had decided to sort of do something adventurous, right? Most of us had never left the country. So we took a trip to East Africa to Nairobi, and just for kicks, in the middle of the touring and stuff, we sat the ECFMG exams. And so I had the ECFMG, and then we decided to sort of emigrate to the United States. So I came over in the early 80s, ended up in the Detroit area, had only $350 allowed exchange in my pocket, borrowed my father-in-law's 1977 stick shift Pinto, and that could only go so far, right? So interviewed at some programs around the Detroit area, heard from Wayne State as the first program that was interested in me, and so signed the contract. Did my residency at Wayne State, moved on to the world-famous Mayo Clinic for my oncology fellowship. My wife finished her pediatrics training, and then we wanted to move to a warmer climate. I had always known by this time that I needed and wanted to stay in academia. MD Anderson happened to have a job opening in melanoma sarcoma department. Everything that I did while I was a fellow and instructor at the Mayo Clinic was in everything other than sarcomas, but this was the opening, so I can't turn this into a very sexy, catchy, nice story that there was a calling. This was the opening. I joined the group, and in a different forum, I can sometimes tell you the stories of what Ed Cragen and Ron Richardson and Larry Coles thought of all that great idea. But here I am. Another 32 years later, initially started doing both melanoma sarcoma because it used to be a joint department. About 10 years into it, separated into 2 departments, just focused on sarcomas, and I've been here now 32 plus years.
That is quite a long journey, as you said. And you know what unique, Shreyas, is probably very similar to a lot of our careers. It wasn't planned. You know, if you said that you wanted to be a sarcoma doctor in med school, in fellowship, we'd be lying to each other because a lot of us, have done different things. And, you can develop a career late in your, let's say, fellowship and do quite well, actually. And I know you do have a lot of contacts with Mayo Clinic, and the names you talked about, Larry Coles, Ed Cregan, and Ron Richardson, are names that I know because you and I trained roughly at the same time, and they do shape your career. Just like you, I didn't train in sarcoma during fellowship. It was just an opportunity, and you came there. So that's quite unique.
And it's the basics that matter, right? I think your work ethic, you put your head down, you kind of figure out yourself what you want to do when you grow up and just do it as best as you can. And I think doesn't matter where you end up applying to, right? It's the basic skill sets of being the clinician investigator is what sort of drives your pathway and career. So
100%. And the reason why I think that's so unique to all of us is that it's never too late to develop a career in sarcoma, and it's showed for you, and we're really excited about that. You've also spent some time in the development of SARC early on, and maybe you can share with the group here kind of how the thought process of how SARC was developed, because we're coming on 20 plus years now.
Yeah, so I mean, it's an interesting story. I think this takes us back to, I want to say 93, 94. There happened to be a wealthy individual from Florida, from the Boca Raton area, who had the misfortune of having a sarcoma. And by virtue of being resourceful, had made his rounds to several name brand academic centers, visiting with physicians who clearly had a name recognition in the sarcoma field, and ended up finding out the hard way that there was no consensus, right? There were differences in opinions, some philosophical, some based on evidence, some just gut feeling, and so on and so forth. So what he ended up doing is gathering a group of people that he had visited in Boca Raton to say, let's get around a table. We've got to fix this problem. And I think part of that group, if I remember correctly, was Larry Baker, Karen Antman, Bob Benjamin, Lee Hellman, Herman Soot, who was sort of the driver, if you will. And Dr. Murray Brennan might have been there. I don't remember that for sure. But a group of these people got together and they did what they did for that patient. But Herman Soot was the one who then came up with the idea that this was wonderful. We all learn from each other. We all are friendly. We all talk to each other, even though we may have different convictions and different opinions. Doesn't stop us from exchanging these ideas, and we should have a forum for this. So he took that on his shoulders and set up the first CTOS meeting at the Copley Plaza in Boston in 94. Backup was also 95. And it started off with probably less than 100 members, and clearly over the ensuing decades has grown to more than 1,000 members. And the attendees tend to be sort of matching that same number. So the idea was for it to be a multidisciplinary organization where all disciplines participated, shared their ideas. And the whole notion at that time was that everybody should be in one room. So, the med-oncs learn about orthopedics problem and the surg-oncs learn about radiation problems and so on and so forth, right? So I think that has worked very well. I think an offshoot of that from the North American group was to sort of come up with a clinical trials organization. I think that was Larry Baker's dream, that it sort of should be a North American clinical trials group, and that should be part of the CTOS. So that's how SARC was born, as a subsidiary, if you will, of CTOS.
So it was out of the original design of a multidisciplinary group that was needed for a patient that started CTOS, the Connective Tissue Oncology Society, and there was a practical need for a North American group of like-minded individuals to come together and run clinical trials. And that's a unique opportunity that I think SARC has filled for many, many years and continues to do so today, running clinical trials. But just like CTOS, SARC has changed. So, you've had a very unique experience leading both Connective Tissue Oncology Society and leading the Clinical Research Committee at SARC and also on the Scientific Steering Committee right now. Can you describe what you've learned in your roles and what you think about CTOS and SARC now?
Yeah, so I mean, I think, as every organization starts off, I think the ambitions tend to be high. I think few things are really fulfilled and fulfilled well. I think a forum for all disciplines or many different disciplines contributing to the management of musculoskeletal tumors does exist. I think CTOS does serve that function very well. It's a wonderful networking opportunity. I think sharing of knowledge, sharing of ideas, educating each other is also a function that CTOS serves very well. I think running clinical trials through that or a subsidiary kind of a mechanism was much harder and much more difficult, right? So I think from the CTOS perspective, though, I think the fact that it allows the international musculoskeletal oncology community, basic science, and all the other clinical disciplines to get together and exchange ideas for the furtherment, if you will, or advancement of management of these patients is a very important function that it serves well. I think ASCO has always done it to a certain extent, but ASCO kind of becomes difficult as the other common tumor types kind of take over much of the attention. So I think CTOS has served a very good function from that perspective. What about CTOS and SARC now? So I think some of it is, as generations move on in some ways, there was a group of people who all had the right idea and the right mindset. They got together, set the stage up in both setting up CTOS and setting up SARC. And that harmony worked very well for a number of years. I think we have to acknowledge the fact that there is evolution, and it's a good thing, right? A lot of things have moved on. Science and understanding has changed. The treatment choices and options and opportunities are changing. At least not everything we investigate necessarily makes it to the finish line, but at least there are a lot more things and different ideas that get tested these days compared to the older days. And that has to broaden the involvement, if you will, right? So I think as newer blood, and that will make me sound old, but I am old and I don't mind admitting to it. As newer blood comes along, I think the previous generation has to make room and accommodate their needs and their wishes, and to a certain extent, let them sort of define the future direction. So the answer to your question, I think, is that the CTOS-SARC relationship has always been strong. I think it continues to remain strong. But some changes in the focus, some changes and modifications in the old way of doing things is inevitable. And I think we have to embrace that change rather than be too overtly critical of it.
No, I do appreciate that. And as you said, one of the values of CTOS is networking. I mean, this is a great show at Vancouver. We haven't been together for a long time, so a lot of energy around networking, and also the science of sharing great information that we might not have a focused attention to is it's very unique at CTOS. And your understanding of that relationship of SARC during that time too, to bring forth clinical trials that served this nice niche in the past will need to evolve, as you said. So in follow-up, how do you see us at SARC moving forward in 23 and beyond?
I think in principle, the details are always harder to come by, but if we have the basic principles in mind, I think the details will follow through. I think we have to be inclusive. We have to be open-minded. We have to be willing to change and embrace the newer way of doing things compared to the older way of doing things. And I think to a certain extent, as we both sit on the SARC steering committee, you in your CMO role, I'm a member, and I think we are trying to show the sarcoma community that SARC is open to new blood, SARC is open to new ideas. The directions that we can take are the same generic directions, right? Is it education? And we have the Young Investigator Awards and Career Development Awards that we support and give out. It is advancing science and advancing therapy for these group of patients, which again gets back to either helping someone run the clinical trials that they cannot, or us try to sort of help younger investigators bring their ideas to some kind of a reality. So it also revolves around clinical trials in some ways. An additional area would be grants and advancing basic science. So the Developmental Therapeutics Committee, as we all know, sort of is comprised of a group of experts in various different areas of basic science, and how to bring that expertise into the sarcoma world and connect each other to try to understand things better and hope to generate newer ideas that can then be tested in the clinic. So these are some of the broader areas, and nothing unique or different that SARC hasn't done before. It's just we have to expand the horizons as new opportunities, new ideas, new people come up and want to participate. And, we should facilitate that and encourage them and help them get to the finish line.
Yeah. No, I like that when you said that we have to be inclusive, 100% inclusive. We have to be open to new ideas and change. And I think the leadership at SARC does realize that, has realized that. I think we have an opportunity to, I don't want to sound old as well, bring in young blood with new ideas and to bring forth ways that we might not have done in the past. One of the things that we have not done in the past prior to, when SARC and CTOS was developed is the active role of patient advocacy groups. I know that you are heavily involved in the Chordoma Foundation. Can you describe historically where you see the evolution of the patient advocacy groups are and how the patient advocacy groups need to be incorporated into sarcoma?
So without a doubt, they represent maybe just as important, if not a more important constituency of all interested parties, right? I think historically, going back a few decades, their role was to educate the patient in terms of what the disease is, who they should go see, maybe the needy patients get some financial help. So whole hand holding, if you will, to walk someone through their journey with a diagnosis that clearly devastates the family. I think as the groups have evolved, they have gotten into philanthropy and generation of money. That then allows them to sort of foster some scientific contributions, allow for discussion of potential clinical trial ideas, maybe even sponsor some clinical trials. And to fast forward, we are almost now at a point where so many different groups are very active in the research and the scientific side that they, figure of speech, they have a seat at the table right from the beginning. If there is a new compound or there is a need for, patient-related outcomes kind of metric, for example, no matter what we are talking about, I think, they are actively participating right at the early level of conceptualization of the trial, not just helping implement it, right? And then they still follow through their other innate responsibilities that, they have the patient population, they can educate them, they can get them on the clinical trials and stuff like that. But they're more integrated, if I can use that term, into the whole infrastructure, as opposed to being a separate entity that clearly always has performed a very useful and valuable function, but they're more integrated into the entire, therapeutic arm, if you will, of organizations. Chordoma Foundation is a classic example. I think there's a dedicated person, Josh Summers, who is a brilliant guy. I would be happy to confess in public that he knows more about chordomas than most other people I know, including me. But it takes a dedicated person like that, and then you see how it has moved from the spectrum that we just talked about, helping patients, to actually generating science, generating clinical trial ideas, supporting clinical trial ideas. And it's also supported by a very dedicated board that tends to be very involved, and I think it takes a village. At the end of the day, that's what will lead to progress.
Yeah, and you bring up Josh Summers as well as the Chordoma Foundation, and you know they have a very strong group, a very focused intention on chordomas. There are other well-organized groups such as LifeRAF with gastrointestinal stroma tumor, the National Leiomyosarcoma Foundation with leiomyosarcoma, EHE, the EHE Foundation for epithelial hemangioendothelioma. The list goes on, and it really builds together members of the sarcoma community that has expertise, has interest, has connections for a specific tumor group. And we just laud and appreciate that there is these dedicated groups out there, and we have to continue in the cooperative groups as well as SARC, as well as MD Anderson and other institutions to support those grassroots efforts that, as you said, have a lot more background and information and leading some of those science along. Some of them even gone to tumor boards, such as the DTRF as well. So you can imagine how all of this is starting to get sarcoma out in the public space. Also getting researchers excited about meeting, networking, the same thing that CTOS does. And then SARC has to then recapitulate to say is we need to engage with them and then also then have the avenue to do clinical trials. So I appreciate, your support of Chordoma and that group, but also the importance of patient advocacy groups as we move forward. Like me, you and I started at one institution and have stayed at one institution. What advice would you give to young and sarcoma investigators as they are developing their careers and relationships that you should have with your local institution as well as other institutions?
Yeah, sure. So, I mean, again, Scott, as you will agree, I don't think I want our listeners to think there's one right or wrong answer, right? Because there isn't, and I think everybody knows this. I think the reasons why one stays at one place or one moves around can be multifactorial, right? There are family-related reasons that might take one from one place to another. There may be career enhancement-related reasons that takes one from one place to another. I think my personal experience and my principle always has been that the individual needs to sort of focus and know what they really want out of a career. I think in general, most institutions will provide that to a certain extent. So if you run into a situation where, the progress is going to be impaired, then obviously they get forced to move on to a different place. So nothing wrong with moving versus staying in one place. I think what matters more, and this may be for our younger generation that may be listening, is it's your focus that matters, right? I think as long as you are continuing to produce, and for that matter, from a personal and family standpoint, you are happy doing what you are doing. And happiness is relative. When somebody asks me, are you happy? I always first question back is define happiness. And that's always a tough one. But in general, I think as long as things are manageable and you're okay, that's fine. I think this is one where I also have to give a plagiarized answer, right? This is not original. This is not mine. But most listeners probably know of Dr. Joseph Simone, right? Joe Simone was a prominent pediatric oncologist who sort of had leadership roles at St. Jude's and at Memorial. And he has written this book, Simone's Maxims. And if some people haven't read it, I would strongly encourage and recommend reading it. And he says one of the maxims, I think the third maxim or so, is don't expect your institution to love you back. So, I mean, there comes the difficult part of the thing, right? So at the end of the day, we all try to function as a family. We try to function as a group, and that's the right thing to do. But I'm also a realist at the same time to acknowledge and recognize the fact that this is a contractual obligation, right? It is a transactional relationship. And if there is that element, that's going to be there. So I think, like the tennis coach tells us, don't take your eye off the ball. Always keep your eye on the ball. And as long as you are making progress, you and your family are happy. Where you are is not the most important thing. I mean, of course it's important, but it will all fall into place.
You bring the word, if you're happy with your family, it's important. And your family is not just medical oncologist. Your family is leading a multidisciplinary sarcoma center that takes time, dedication, and commitment. What lessons have you learned in developing and managing a large multidisciplinary sarcoma center?
I think the biggest principle I try to follow, I hope I do well, but at least what I try to do is, I think there has to be mutual respect. There has to be openness in the sense that, the problems, issues, day-to-day routine of surgical oncology may be different than orthopedic oncology, may be different than radiation oncology, may be different than medical oncology, right? So I think when we try to get into, and this is one of my criticisms of the current era, where we try to, fit a square peg through a hole, if you will. We have a one-size-fits-all approach. And I personally don't think that that gets us anywhere, right? I think there has to be individualization, personalization. This personalized treatment and personalized issues are not a new thing. I think, we've always tried to personalize things in life and in medicine. So my biggest issue is we have to be respectful and open to the individual needs of the different constituencies that we represent. And I think as long as we are respectful, open, communication is a very critical component of it. I think if we don't talk and don't communicate, that's where problems seem to arise. But where there is respect, where there is communication, where there is openness, even where there is some fairly significant disagreement, we can always find a middle path, right? Or at least find a path that people can live with. I think agreeing to disagreeing is not an unusual or uncommon thing in life in general, and no different in this business. So I think as long as we have that, we can continue to not only just survive, but even thrive. I think newer ideas come along, kind of like we were talking about SARC earlier. Same thing for individual multidisciplinary centers. I think, running my center, I mean, I'm not a techie guy, but I have some colleagues who are absolutely techie. And that always brings newer ideas and better ways of solving old issues and old problems far more efficiently.
Dr. Patel, it sounds like you should be a family counselor, a marriage counselor, because the open mutual respect is something that we all could use a little help on. And it sounds like you've done a great job of doing that at MD Anderson. And one of the questions I asked in thinking about it is, you've done this for a while. What surprises you today about a multidisciplinary group that you probably never thought about 20, 30 years ago?
I think in many ways, we have blended so much better together. I think I can remember days wherein we all worked side by side, but there were silos. Medoncs did the Medonc thing, and Surgeoncs did the Surgeonc thing, and the Radoncs did the Radonc thing, etc., etc. Overall, I think everybody's more open, more interactive, more willing to collaborate and cooperate. The respect part becomes very critical. And I think this may be related to another topic we'll be discussing down the road too. I think while, in my opinion, in my experience, almost all individuals are willing to be collaborative and cooperative, we have to acknowledge and accept the fact that there is competition. Ignoring it does not help, right? And I think at one of the CTOS meetings several years ago, there was a panel discussion, and I remember saying this sitting up at the podium, that academia by nature is competitive. And unfortunately, there was pin drop silence. But my reason to bring it up in that setting was that if we try to hide away from it and run away from it, I think it does us a disservice. I think we have to acknowledge the fact that there is one first author, one last author, everybody else gets crammed in the middle and nobody cares. We all have different masters to please, right? You've got your own goals to fulfill. You've got your family pressures that sort of modify them in some ways. You've got your institutional masters. You've got the cooperative group responsibilities. So there are multiple masters to please, and that's just the reality. That's life. So I think acknowledging that would allow us to then come up with concessions when they are most appropriate and have a rotational scheme and be fair and, equally distribute credit rather than someone hogging it all the time kind of thing. And these are the things that become very critical. I think the way we describe it in this current day and age is emotional intelligence. And my criticism of that phrase is that emotional intelligence, unfortunately, in the current day and age, seems to imply that you can never speak the truth. You can't say anything that may be remotely bad or not good. And I am still an old-fashioned person. I think the truth is the truth, even if it sounds not so pleasant. If it's important for us to embrace it so that we don't become victims of it and we can come up with a solution for it, I think is absolutely important and critical.
The concept of emotional intelligence, speaking the truth in a kind, considerate manner is important. And as you said, it has to be done in a way that fosters collaboration. So you're right.
I have to give you a quick anecdote. I mean, there was a few years ago, there was some administrative meeting. Everybody was sitting around the table. 40 minutes into the hour, we're discussing about a issue with a individual, but all this emotionally intelligent, polite way of saying things were just not working. And I finally had it, I guess, right? That's my blunt old self that sort of manifested. And I kind of said, you've tried to call a blind individual visually challenged and variety of other, figure of speech words for more than 6 months. The message is not getting across. You're not seeing any results. I think it's time to pull the individual and say, I'm sorry, but there is blindness here. You're blind. Now, calling them blind is not necessarily bad. It's a factually correct statement. But the point was that there was pin drop silence again at the table. No one wanted to sort of embrace that idea. And I think that in the most polite and respectful way, there are truths and facts that we have to embrace and solve problems. Shoving them under the rug and pretending that it's going to go away on its own, I think only does harm to the entire group. And I don't think that's fair or appropriate.
So I know if I'm not doing something right, Shreyas, you're going to tell me I'm not doing right, and don't beat around the bush. So that's good.
Yeah, I've tried hard to learn that technique. I just can't master it, I guess.
Yeah, exactly. We have a lot of young trainees, a lot of people that have been trained by people like yourself. You and I have been mentored at MD Anderson. I've been trained as well as you at Mayo Clinic, and we've learned a lot from our mentors. Some are great leaders, and we've learned a lot. As you think about this and reflecting a little bit, what lessons did you learn from your mentors, and what lessons and pearls do you try to pass on to your mentees? Now, you might not think you are a mentor, but you've been around long enough that everybody would say that you are a mentor now. But what do you try to pass on?
So Ed Kragen once told me, be a sponge, absorb the good things from everybody. And I have a great fondness for Ed. And interestingly enough, I tell my fellows the same thing, that, none of us are perfect. I mean, fellows, as you know, rotate through all different disciplines, right? Breast, GI, GU, thoracic, etc., etc. And I said, as you make your rotations in the first year of your fellowship, you're going to get exposed to a whole host of different clinicians. I think you need keep your eyes and ears open, absorb the things that you clearly are impressed with and like and good, then you shape your career based on that, right? So it's always a blend. It's always a amalgamation of some strengths that you learn, pick up, absorb from your mentors. And then the two other things I tell them is that, don't lose your focus. This is not elementary school anymore. You don't get an A for effort. Stay focused on the projects you pick and things you want to achieve in life and bring them to some kind of a completion. I mean, I translate that in black and white by saying, what doesn't show up on your CV as a line item 2 years later, 5 years later, did not happen, right? So stay focused and try to bring things to fruition. And then comes, one of the several Winston Churchillisms that I've always liked. Churchill said, success isn't final, failure isn't fatal, but it is the courage to keep moving on is what counts the most. And unfortunately, that's how we have to live in life, right? So as you define success and define failure, each one of us has successes to count for, what we would call failures. But that's important, but not the whole point, right? I think what you do with your life is what matters the most. And that's what I tell the mentees. It doesn't matter where you end up, doesn't matter what you do. What you do it well, do it right. And hopefully that gives you some gratification, because at the end of the day, you go home unhappy, you're going to create unhappiness all around you. And we all want happiness at home.
Here. That is exactly correct. I think what we're going to have to do is create a book on the Shreyas Patel Maxims, because now you've added some more Maxims to all of our list here. And I'm going to have to be a sponge as well.
I'm not nearly that wise, Scott, but thank you.
I have one last question here before we end here that, you've been around a long time, and I'll just pose this. If you were given a magic wand to improve sarcoma infrastructure, what would you want your wand to do?
I think as we've talked throughout this last several minutes, we've made progress as a group over the last couple of decades. I think the group is a lot closer to try to accomplish things. But if the wand was unifocal and did one thing, I would want it to create a whole bunch of money in the backyard, grow money in the backyard, so that no good idea or no good endeavor gets nixed or cut or killed because there is no financial support. I do think that the will is there. As we all know and recognize, more ideas are coming along in terms of, based on the understanding from the lab, what else can we do? How can we improve therapy and so on and so forth? But you and I both know that how many of these kind of get modified to the extent that they are doomed to fail, or don't even get off ground simply because there isn't enough money to be able to do it. So, I guess at the end of the day, money talks. If the magic wand was to generate a lot of money, I think the will does exist and the progress would sort of happen faster. We can get into the nitty gritty details of the forest, and the finer details may be nice to have technology, nice to have personnel, nice to have this and that. But I think none of that is going to work if there's no money.
As you know, no money, no mission. So that's a Maoism. So I'll just throw that out there. And I think your comments are spot on. We never want to have a great idea die on the vine because we don't have any funds. And I think the sarcoma community is out there and can definitely support science, support clinical trials, and support all the efforts that the patient advocacy groups are doing, as well as SARC. So we do appreciate it, Dr. Patel. Any additional final comments?
So one final thing, a correction. I think I might have misinterpreted your question at the very beginning. I think as I'm looking through this, you asked me about the history of the formation of SARC. And I think I kind of drifted into the CTOS and then trickled on to SARC. But SARC was the baby created by, a group of people. I think Larry Baker was clearly the brain behind the whole thing. Bob Benjamin was the close second, as we used to call them, the killer bees back then, the Benjamin Baker team. And right in there was Bob Mackey, who was instrumental. George Dimitri was there. I think these were the first 4 founding members of SARC, if I remember correctly. And then, I have to give credit to a lot of our European colleagues, Piero Picci from Italy, Frits Coverden from the Netherlands, to name just a few. But so many of them were very willing to establish this transatlantic collaboration and cooperation. So that's how SARC started. And then, clearly CTOS formed first, then came SARC, and I think there was close integration at the very beginning, and there still is a very close tie, as we talked about earlier. But other than that, I think it was a pleasure. I'm glad we got to talk about things. This was fun, and thank you for all your efforts on behalf of SARC.
No, thank you, Dr. Patel. Thank you for spending time sharing your thoughts and perspectives on sarcoma, what's going on at MD Anderson, CTOS, SARC, and your continued dedication to the sarcoma community. I think you've shared a lot of good information, and as you said to us, we have to be sponges. Now I have to go back and listen to everything you've said and pull out everything that you've said, so we do appreciate it. Please share SARC Talk with those that are interested in sarcoma. Please leave comments and suggestions on our SARC Talk podcast, and we'll address them at our next SARC Talk. Our next SARC Talk will be we'll be speaking with Angela Herbie, as well as Dr. Laura Davis. Both of them are Career Development Award winners in the past, and they were given together. And we'll look forward to hearing what they will have to say about sarcoma and their paths as well. Again, thank you, Dr. Patel, and we look forward to continued work together. Thank you.
Thank you for listening. Be sure to subscribe so you never miss a SARC Talk. To find out more about SARC, please visit our website at sarctrials.org. To suggest a topic or ask questions, please email us at sarctalk@sarctrials.org. And remember, together we can find a cure for all forms of sarcoma.